Okay, good afternoon. Thank you, Chairman, for the introduction, and thanks for the organizing committee for the kind invitation. So my talk today is about isolated leukocytoclastic vasculitis. So I'm going to start with some definitions. Purpura in Latin is purple. In medical terms, it refers to an unblanching purple rash that results from extravasation of the blood vessels. Causes of purpura ranges between non-inflammatory causes caused by collagen disorders or inflammatory causes like vasculitis or collagen and platelet dysfunction, which typically presents with an unpalpable purpura. So what is cutaneous vasculitis? Cutaneous vasculitis refers to inflammation of the blood vessels present in the dermis and subcutaneous tissue. It can range from a very benign, self-limiting disease to a recurrent severe disease with life-threatening organ failure. What is leukocytoclastic vasculitis? So it's the histopathologic terms that defines vasculitis of the small vessels involving arterioles, capillaries, postcapillary venules that can be found in the skin and internal organs. So to diagnose leukocytoclastic vasculitis on skin biopsy, you have to have evidence of neutrophilic infiltration, fibrinoid necrosis, signs of damage, and thrombi in the lamina of the blood vessels. You have to have at least the first two, so the neutrophilic infiltration and the fibrinoid necrosis. To classify cutaneous vasculitis, you have many methods. So it's considered to be limited to the skin only if the systemic organ involvement is ruled out. Vessel size, so we can divide it according to the vessel size, small, medium, and large, and the histopathologic findings. So cutaneous leukocytoclastic vasculitis was classified under single organ vasculitis in the Chapel Hill criteria. However, more recently, a dermatologic addendum was done to that criteria, which updated the formal classification in 2019, recognizing that cutaneous vasculitis can be present as, number one, a skin component of a systemic vasculitis, or a skin limited or dominant vasculitis, or a single organ vasculitis. So I'm just going to show some cases from just to highlight or to show these differences. So the first case is a 29-year-old male patient presented to the clinic with ankle arthritis and vasculitic rash on the lower extremities. He also had recurrent nosebleed. Workup was sent, however, he presented to the ER 2 days later with hemoptysis. The patient was diagnosed to have C-ANCA vasculitis with pulmonary hemorrhage. So this patient has a skin component of a systemic vasculitis. The second case is a 48-year-old female presenting with on and off urticarial rash and no other systemic symptoms and sign. But on her investigations, her ANA was positive as well as the double-stranded DNA. So this patient has lupus, but her presentation was skin-limited. The third case is a 23-year-old medical student presenting with painful rash on her fingers and inflammatory arthritis. Her ANA anti-Smith were positive. Her skin biopsy was positive for vasculitis. So this patient has a skin-dominant expression of lupus. The last case is a 20-year-old female, known case of ulcerative colitis, was initially controlled on adalimumab, however, was switched by her gastroenterologist to infliximab for secondary failure. 2 months later, she developed this cutaneous lesion. So this patient has single organ vasculitis limited to the skin, likely secondary to anti-TNF. So to classify cutaneous vasculitis based on the vessel size and histopathology, if we're starting with small vessel vasculitis, hypersensitivity vasculitis, urticarial vasculitis, IgA vasculitis, all of those presents with mainly neutrophilic infiltrates with an immunofluorescence test that is positive, whereas viral infections, lymphoma, for example, presents mainly with lymphocytic infiltrates. If you have a mixed medium, a small medium vessel vasculitis that is present in cryoglobulinemia, rheumatoid arthritis, where they have neutrophilic infiltrate with a positive immunofluorescence testing, whereas ANCA vasculitis present again with neutrophilic infiltrate, but they have negative immunofluorescence. If you have a medium to large muscular blood vessel vasculitis, you will find neutrophilic infiltrate in polyarthritis nodosa or cutaneous arthritis, whereas GCA and Takayasu, you will have mainly granulomatous infiltrate. So what about the clinical presentation of cutaneous vasculitis? If the involvement was mainly small vessel, purpura will be the most common presenting symptoms, but other includes petechiae, vesicles, hemorrhagic blisters, and pustules. So these are some of the small vessel vasculitic presentations. So you can see petechiae, purpura, confluent purpura. Another small vessel vasculitis involvement is urticarial vasculitis, where you have a hive-like or urticarial wheals. The lesions tend to persist longer than 24 hours. They tend to burn, not itch, and they may leave a bruise behind. Urticarial vasculitis can be divided into two categories based on the complement levels. So if you have a normal complement, it's mostly idiopathic. But if you have a low complement, so this is anti-C1q vasculitis, that can occur with systemic disease such as lupus or drug hypersensitivity. Other clinical presentations, as you can see in this image, the patient has erythematous plaque, lividoreticularis, bullous hemorrhagic lesions. What about if the patient has a medium vessel involvement? You have different cutaneous manifestations, including ulcers, nodules, scars, and lividorasmosa, as in the last image. Other medium vessel vasculitis lesions, you can see digital necrosis. As you see in the first image, this patient has PTU-induced ANCA vasculitis. The second one has retiform purpura from GPA, and the third patient has extensive ulcers with areas of necrosis, and this patient has MPA. Retiform purpura can be, or the differential diagnosis of this lesion can be seen in vasculitis. However, we can see it in pseudovasculitis cases, which are non-inflammatory conditions like antiphospholipid antibody, calciphylaxis, heparin warfarin-induced skin necrosis, or cholesterol emboli. So what are the complications of small vessel vasculitis or cutaneous small vessel vasculitis? They may progress to systemic or development of systemic features. Local ulcerations may lead to wound infections, cellulitis, chronic leg ulcers, and scar formation. So what are the causes of leukocytoclastic vasculitis? In 50% of the cases, you will find an underlying systemic disease, but the other 50% are just skin limited, and they can be subdivided into drug or infection induced or idiopathic with no clear cause. So the causes based on the Chapel-Hill criteria are ANCA vasculitis, immune complex vasculitis, vasculitis associated with a systemic disease, or vasculitis associated with a probable etiology such as infection, cancer, or medication. So drug-induced vasculitis is a diagnosis of exclusion. Eosinophilia is common in systemic drug-induced vasculitis and is seen in 79% compared to 22% in patients with skin-limited drug-induced vasculitis. And here are some of the medications that may induce vasculitis in the skin. There is a number of infectious agents that causes vasculitis, and I just listed some of those. Autoinflammatory disorders as well can present with cutaneous vasculitis. This picture shown is from a patient with deficiency of adenosine deaminase 2. What about COVID-19? So COVID-19 infection can cause transient vasculitis in the skin in mild cases of COVID in younger patients. And also in patients with severe COVID pneumonia, they may have cutaneous vasculitis secondary to thromboembolic disease. What about COVID vaccine? There has been a number of case reports with patients developing cutaneous vasculitis 7 to 10 days after vaccination. So what is erythema elevatum diutinum? So this is a rare necrotizing vasculitis. It's classified as a small vessel vasculitis. Patients present with red or brown papule that develops and persists for years. It has been associated with some recurrent infections and also with rheumatologic disease. On skin biopsy, it does show leukocytoclastic vasculitis. It does not really respond to prednisone, and it's treated with dapsone. Exercise-induced vasculitis occurs in healthy patients. It occurs typically after exercise, especially if the weather is humid and warm. The skin biopsy confirms leukocytoclastic vasculitis. It is self-limiting disease and is treated with just stopping the exercise, elevation of the limbs, compression stocking, and symptomatic treatment. So how do you approach a patient presenting with purpura? If it was not palpable, so non-palpable, you have to consider thrombocytopenia, coagulation problems. But if it was palpable, then you have to do a skin biopsy. After that, you have to do a thorough history physical exam workup to decide whether the patient has a limited skin disease or have a systemic vasculitis. So history should be head-to-toe history, like when you assess any patient with vasculitis, but you should also include potential triggers like preceding infections, drug vaccination history, and comorbid medical conditions. Workup includes CBC. You have to check the kidney function with microscopy. You have to rule out infections, malignancies. You have to send a full rheumatologic workup, proper imaging, and a skin biopsy. So important patterns to recognize. If you have a patient who had a single course of vasculitis, that's typically secondary to a drug or an infection. A patient with a recurrent bout of vasculitic rash with periods of remission in between is typically consistent with HSP. However, a patient with chronic persistent occurrence of leukocytoclastic vasculitis is mainly observed in patients with systemic small vessel vasculitis, connective tissue disease, or cancer. So a skin biopsy should be done to confirm the diagnosis. A deep and large punch biopsy, 5 to 6 millimeters, or even a deeper excisional biopsy to determine problems with medium vessels should be done. Lesions should be sampled within 48 hours of their occurrence. Ideally, a biopsy should be done before starting steroid therapy, as immunofluorescence may be biased. So how is immunofluorescence testing important? The presence of perivascular IgA is consistent with HSP, whereas the presence of IgM is mainly consistent with rheumatoid arthritis and cryoglobulinemia. C3 and IgG deposition, like in this image shown, is consistent with lupus. Polyarthritis nodosa and ANCA vasculitis typically have a negative immunofluorescence. So again, the histopathologic findings, as we mentioned previously, you can see in the figure A, there is heavy neutrophilic infiltrate in the dermis. And with the arrow in A and B, you can see areas of fibrinoid necrosis. The last picture D, it shows a typical IgA deposit, which is consistent with HSP. So to treat leukocytoclastic vasculitis, you have to assess whether there is organ involvement or not. If you have a systemic vasculitis, then you will follow the treatment guideline of that disease. If it was skin limited, you have to eliminate probable etiologies such as infections or drugs. Otherwise, if you have an idiopathic primary cutaneous vasculitis, you have to assess the severity, if it was recurrent or chronic. So if a patient has complicated lesions, which are hemorrhagic, ulcers, recurrent, or more than 4 weeks duration, then you have to consider starting steroid at a dose of 0.5 milligrams per kilograms and continue that until the new lesions stop to appear. After that, you would continue steroid for at least 2 weeks and start gradual taper. If there is a relapse or inadequate response to steroids, there has been small studies looking at colchicine and dapsone. If the patient is still not improving, then you have to proceed to immune suppressants such as azathioprine, mycophenolate, and methotrexate. There has been case reports using rituximab in refractory cases of small vessel vasculitis, cutaneous vasculitis with good results. As you know, rituximab has an established role in other vasculitides, for example, ANCA vasculitis, cryoglobulinemia, and urticarial vasculitis. So take-home messages, skin abnormalities can be the first indicator to a systemic vasculitis or a connective tissue disease. Collaboration between rheumatologists and dermatologists is necessary to facilitate proper and quick diagnosis of cutaneous vasculitis. Detailed history, physical exam, appropriate workup is needed to reach a proper diagnosis. Skin biopsy can be done or should be done to confirm vasculitis and to rule out other causes of pseudovasculitis. Skin biopsy should be done early for accurate results, and another non-formalin sample should be sent for immunofluorescence. And thank you very much.